So if there are no further comments, we can move on. We can move to our next talk by Dr. Fairooz. Ma'am will be talking about orbital inflammation and Enigma.
Thank you, Gunjan. I'm going to share my slide here. I hope it's visible and I'm audible.
Yes.
Yeah, respected chair, co-chair, mentors who are in this platform, dear friends and colleagues. So I will be talking on orbital inflammation today here. In fact, indeed, orbital inflammation is a very interesting topic, but equally challenging for an orbitoculoplastic surgeon and the patient as well. And I'm just going to go through a brief overview in the next 8 minutes. Here, I have no financial disclosures or interest. So according to Rootman's classification, orbital inflammatory disease is broadly classified as specific, which can include granulomatous, which definitely has an etiology and a cause, or even vasculitis, as you see in this case over here, where a patient has vaginous granulomatosis and a presentation was with very painful proptosis, and she also had nephropathy. So this is basically specific etiology-oriented inflammation in the orbit. Now, this is a 65-year-old lady who presented with diplopia and discomfort in the right eye, as you can see here. On imaging, the CT scan shows a very diffuse lesion involving the inferior and the lateral orbit, also including the inferior rectus muscle, and this is the MRI showing the inferior rectus muscle involvement. And in fact, this was referred to me as a case of orbital inflammatory disease. So anterior segment evaluation, this is what I found. The bulbar conjunctiva had multiple granulomas. So this is very, very classical and characteristic of sarcoidosis. And the only thing that I did was to go and take a biopsy of the conjunctiva and not that of the orbit. And she was proven to have sarcoidosis and was treated conservatively. Now, going on to the non-specific ones, the current terminology is idiopathic orbital inflammatory disease, which is a space-occupying lesion in the orbit, which is non-neoplastic, non-infectious, and it is a diagnosis of exclusion. So most commonly seen in adults unilateral, but yes, rarely we can see it in children as well. And sometimes it can be bilateral, it may be diffuse involvement of the orbit, or it can be localized in different locations. It could be an anterior IOID, it can be a posterior one, including the lacrimal gland, which is dacryoadenitis, myositis, apical, or even perineuritis. So this is a 12-year-old child who presents with recurrent periocular puffiness and swelling. And this is how she looks like. She has definitely periocular swelling, there is hyperemia, and she has severe photophobia. Anterior segment evaluation showed anterior uveitis, and ultrasound B scan evaluated showed tenonitis. So this is a case of an anterior IOID. So this is how important an anterior segment evaluation is in an orbital case, especially when you're suspecting an inflammation in the orbit. Well, she was treated with oral steroid and she did have a recurrence and finally settled with intravenous methylprednisolone. 38-year-old gentleman who presented with blurring of vision in the right eye. His best corrected visual acuity was 6/60 with diplopia when he presented. Color vision was abnormal. You can see the right eye is dilated. He had an RAPD, and this is the imaging evidence of lateral rectus involvement, which is enlarged, and he had perineural inflammation as well. So this was a case presenting as myositis with optic neuritis, who was again treated with intravenous methylprednisolone, whereas actually the vision improved to 6/6. So this is a case of a 20-year-old student who presented with severe acute swelling of the left eye, as you can see here, and there is also an S-shaped ptosis of the right eye with periocular puffiness. So, the best corrected visual acuity when she presented was 6/60 because of the globe indentation and choroidal folds that she had at the fovea in the left eye. And there is evidence of an enlarged lacrimal gland in the left eye with globe indentation over here. And of course, there was enlargement of the lacrimal gland of the right eye also. And it was a case of bilateral dacryoadenitis. So 30 to 50% of lacrimal inflammation have associated systemic disorder, and it can be a simulating lesion. And this has to be ruled out before you term it as an idiopathic orbital inflammation. So in this paper of 97 cases, they found that 30% was idiopathic orbital inflammation and 20% accounted for sarcoidosis. So this patient had a recurrence in May 2018, and then she had a severe recurrence again. And at this point of time, we re-imaged, and we found that there was enlargement of the lacrimal gland, as well as there was some amount of bony erosion of the roof. And we went ahead with a biopsy at this point of time. So she went ahead with a lid crease incision biopsy, and this was proven to be a sclerosing variant of IOID with vasculitis. The entire serology profile for autoimmune disorders was done. It was within normal limits. The IgG4 was ruled out. And India, being an endemic country with tuberculosis, with a quantiferon gold test positivity, she was also put on ATT, and then she did well. And for the past 3 years, she has been stable. This was a lady, a 56-year-old lady, who presented with proptosis associated with severe pain. In fact, with an ENT, she had undergone an endoscopic orbital biopsy, and the conclusive result was not available, and the pathology report only stated vascular tissue and fat, and she had a loss of vision post-surgery. When she presented to us, it was PL negative. And this was what we found. The medial rectus was enlarged, severe thickening of the medial rectus muscle. In fact, there is involvement of the paranasal sinus, but of course an endoscopic surgery has been done in this patient. We went ahead doing a biopsy in this patient, and this came out to be a sclerosing variant of idiopathic orbital inflammatory disease. So biopsy is really, really important in such situation, because orbital myositis can have different etiologies. It could be including autoimmune disorders, and very rarely it could be a lymphoproliferative disorder as well. And as far as orbital myositis is concerned, in idiopathic orbital inflammatory disease, medial rectus is the most commonly involved as compared to the inferior rectus that we say in thyroid eye disease, which is again a very common cause for myopathy, as Dr. Milind has already presented, followed by lateral rectus, superior rectus. This is a very interesting case that I really, really wanted to take you through. This patient presented in 2017, where initially he was diagnosed to have thyroid eye disease. He didn't have upper lid retraction or a lower lid retraction. The only thing that was evident was a medial rectus enlargement in radiology, and he was euthyroid. In due course of his disease, as he progressed, there was involvement. Initial involvement was the inferior rectus, and that's why the referral doctor had diagnosed it as TED. But in due course of time, the medial rectus muscle, the lateral rectus muscle, and even the superior rectus LPS complex got involved. And this is how he recurred at different phases in his journey with myositis and idiopathic orbital inflammatory disease. And this is how the treatment was given. He, in fact, received a total of 7 grams of IVMP with multiple recurrences, a systemic azathioprine, and even intraorbital triamcinolone acetonide, and even 1 injection of rituximab was tried. And in fact, the journey was very, very frustrating for the patient. Ultimately, in 2019, it became mostly silent, and this was in 2021 that we had seen, and he had no recurrence. This is a very interesting case where the patient presented with history of redness in the right eye since 2 years, and he has noticed that his eye is bulging for the past 6 months, and for the past 4 months he has noticed that there is a nodule which is appearing in the lower lid, and it has been progressively increasing. On examination, this is how you see it. There is actually a bulky lower lid. There is proptosis almost 9 millimeters with Hertel's exophthalmometry, and this is a salmon colored lesion in the conjunctiva. So with this clinical presentation, in fact, I was almost sure that this could be a lymphoproliferative disorder. Well, his imaging showed that the entire inferior orbital space was involved with the lesion, including the medial rectus, the inferior rectus, and the lateral rectus. And this is how diffuse the lesion was. So all I did was an inferior fornicial incision and went for an incision biopsy. And this was what we found. This is a very characteristic histopathological presentation of, presenting with storiform fibrosis, which is seen in IgG4 related disease. And you can see there's predominant lymphocytes, lymphoid nodule. The immunohistochemistry also showed IgG4 in plasma cells, and the serum IgG4 was much, much higher. The normal level is 135, and this has, elevated to 250 milligram per deciliter, and this was diagnosed as IgG4 related disease. So this is a very interesting paper which was published, and they found in 25 patients with biopsy proven idiopathic orbital inflammation examined, around 40% were IgG4 positive. So this is something that we have to keep in mind with patients presenting with idiopathic orbital inflammatory disease. IgG4 related disease has to be ruled out, and this is how he looks like after systemic steroids. A very interesting case, diagnosed as myositis. She was put on steroids, but there has been recurrence, and this is how her superior rectus LPS complex is enlarged. Well, a biopsy was done, and this came out to be a non-Hodgkin's lymphoma. So even lymphoproliferative disorders can simulate an idiopathic orbital inflammatory disease. And this is what I really want to highlight here today, the role of biopsy. 30 to 40% of biopsied inflammations are associated with a specific disorder, and they can be a neoplasia also hiding along with other autoimmune disorders or granulomas. So the take-home message from this presentation today is idiopathic orbital inflammatory disease is definitely an enigma. It can present in various clinical forms, which has to be, ruled out, and it is a diagnosis of exclusion if you call it idiopathic. And biopsy, histopathology, and immunohistochemistry is really essential in diseases which is not responding to treatment. Of course, systemic evaluation accordingly. Thank you very much for your patient listening.